Good evening and happy New Year. I welcome all the dignitaries, office bearers of Central IIP, EB members, Maharashtra IIP, EB, our AHA members and delegates and academicians who have joined from various parts of India. Once again, welcome, and I hand over to moderator Dr. Swati Likhite. She is our Vice President AHA Raigad branch. Welcome, Dr. Swati.
Thank you, dear Chitra Madam, for your kind words. Myself, Dr. Swati Likhite, on behalf of Raigad IIP branch and Maha IIP, wish each and everyone a very happy new year filled with positivity, joy, and new opportunities in our professional lives. Let's raise a toast to teamwork, collaboration, and share journey ahead. May this year too bring our branch great opportunities and success. Today, we have two very interesting topics to discuss. First one being brain network and adolescents alcohol use, and second one, pancreatitis in children. The experts and speakers are going to make the topic very easy to understand, and they are going to give us some take-home messages. So without wasting any time, let's begin. So now I request our Maha IIP President, Dr. Ram Gopal sir, to give his welcome address.
Yeah, good evening, ma'am. Sorry, I
Good
was
evening.
busy, little busy.
Sir has not joined.
Yes, he is
Good
there.
evening, sir. Thank you.
No, I just came for 2 minutes. Actually, I have to go for a LSC,
He
is what
is
Ramon
there.
just called me. Yeah. Hello. Can
हाँ,
you
sir,
hear me?
बोलो. Yes, sir. Please
Yes,
start.
sir.
Please
Yeah,
start.
yeah. Welcome all. As I had promised you people that we will continue this program in the 2024 also. So already I have told the scientific team to continue with the program. And as we had promised, we have increased the capacity of Zoom also. Now it will be 500. So next time we can accommodate more people. All the best, Chitra madam and Mohanty sir. Amol, over to you.
Thank you so much
Swati
for
ma'am.
your kind words, sir. Now I invite our Maha IIP past president, Dr. Gangolia sir, to welcome and give his blessings.
Thank you,
Gangolia, sir.
Dr. Swati. Thank you, Dr. Swati, madam. Happy New Year to each one and all attending this meeting and respected dignitaries and office bearers of Maha IIP, IIP Raigad, AHA Raigad, our incoming new president, Dr. Ram Gopal of Maha IIP, as well as Secretary Dr. Amol, and all the best wishes to the dynamic incoming leader, Dr. Ram Gopal. Always he spoke just now. He's continuing this program. Just a brief background I want to give because we are starting a new year on a new 1st of January 2024. I remember it was during Doctor's Day of year, July 2021, 1st of July. Just myself, Dr. Jay, Dr. Mohanty, sir, and Dr. Chitra Kulkarni madam, we had a short discussion. We remembered our PG days and thought why not to start the journal club journal reading. And that's where the idea was initiated, and it turned out to be journal journey from IIP Raigad. Then it was the president, Dr. Sunita Ingle madam, Dr. Nilima Bhandarkar secretary, and Dr. Chitra Kulkarni vice president. Under their leadership, we started this program Doctor's Day in year 2021, and it went on. And when I became IIP president 2022, it continued with IIP Raigad. And this program was launched for the first time, it is really to note that Dr. Basuraja sir was there during that launching. And again today, this first of his office day, All the best wishes, Dr. Basavaraja sir, for your, it will be a definitely memorable year 2024. And we are happy to see you once again on the first day of our office at our first day of the program of Maha IP as well as IP Raigarh during July this 2024. And then I'm very happy to note that the incoming president, Dr. Ramakant Patil sir, also continued along with the secretary, Dr. Amol Pawar, as well as again in 2024, it's Dr. Ram Gopal who is continuing with this program. Very, very thankful, heartfelt thanks from myself as well as IP Raigad family to all, to both presidents to continue. Dr. Ram Gopal, if you are there, thank you very much. And as well as Ramol is there to continue this
Yes,
program.
sir. Thank you
I'm
and
very-
welcome again.
Yes, and all these 2 years, it was a wonderful work done by Dr. Neha, Dr. Chitra Kulkarni madam, Pallavi madam, all this, and Dr. Vishal, I remember Dr. Vishal was there, and all the strong teamwork, and it continued in the year 2023, and it will continue in 2024 also. This teamwork will be doing wonderful work. And I welcome today's presenters, Dr. Purva Jain, Dr. Rajeshri, and as well as our expert, Dr. Atul Kanikar sir, and Dr. Vishnu Biradar sir, for their experts' comments. And lastly, and not the least, Dr. Nimen Mohanty sir, if you are there, thank you very much for giving and always giving your ideas in and help to continue this activity. And really, Dr. Chitra Kulkarni working very much hard for that. All the this IP Raigad AHA members doing wonderful work for the journal journey. Wishing all the best for this team, as well as IP Raigad President Dr. Vikas Sahan, seeing him, and Dr. Ajay Kohli, all the best wishes for, they are continuing this year. So 2024 will be also their year. And so all the best wishes, Dr. Vikas, for a year also in 2024. Thank you very much.
Thank you, Dr. Gangolia sir, for the kind words and your blessings. And now I invite our young, dynamic Maha IAP Secretary, Dr. Amol Pawar sir, to give welcome address and introduce our today's chief guest, Central IAP President, Dr. Basavaraja sir. Over to
Thank
Dr.
you.
Amol.
Thank you, Swati ma'am. It has been a really wonderful journey with Gangolia sir as a president in 2022, and then Dr. Jay Bhandarkar sir, Dr. Mohanty sir, and Dr. Chitra Kulkarni ma'am, Neha, Vishal, everyone contributed to the success of this journal journey session. And there are many queries out of state also, that why can't you join us in this? Means why can't you invite us for this journal journey presentation and all these things? So last year also with Dr. Ramakant Patil sir as a president, we continued this program, and everyone was eagerly waiting for first day of each month. Now today we have with us Dr. G.V. Basavaraja sir. He is the current president of National IAP. He today only he has assumed the office. He have now gone back to Bangalore, and the other guest, Dr. Vasant Khaladkar sir, he might be joining soon during this webinar only. He is reaching Nagpur. I thank Dr. Atul Kanikar sir for accepting in a very short notice, and Dr. Vishnu also. And I wish all the best to presenters Purva ma'am and Rajeshri ma'am also. So Dr. G.V. Basavaraja sir is a past Secretary General of National IAP, and everybody has seen his work during COVID times along with Dr. Bakul Parekh sir. He is a very visionary leader, and he has been called as a mitochondria of National IAP in past, and now he has taken a mission as a president of National IAP. So missionary leader, he is now called by his well-wishers. So I thank him for joining and ask him to give his words of wisdom to the Maha IAP and Raigad IAP's joint program, Journal Journey.
Amol,
Yes.
before Basavaraja speaks, before Basavaraja sir speaks, in year 2022, we had Goa state involved, we had Gujarat state involved, we also have Andhra Pradesh involved. In 2023 also we tried to do, probably now also you are there. as a EB member of MAHA-IP at CIP, as well as Dr. Baswaraja sir is there, we can extend this program to other states also, and we can make a coordination committee probably, maybe. And so you are also the joint national coordinator for the action plan. So probably we will look forward to more states getting involved. And wonderful.
Yes.
And only one thing I wanted to say, our aim of this journal journey was that general pediatricians should read the articles. And what it is usefulness, it is impact on our general practice in during the general as a general pediatrician was the aim actually. But now sometimes we lost the way somewhere. We will try to achieve again under the dynamic leader, Dr. Ram Gopal, as well as Amul as a secretary. Yes, Dr. Baswaraja sir. Sorry to interrupt, sir.
Yeah, thank you very much, Dr. Hemant Gangolia sir, and the very kind words from our Secretary of MAHA-AP and the Joint National Coordinator of a National Action Plan Program of Indian Academy of Pediatrics, Dr. Amul Pawarji. Of course, the dynamic president of an MAHA-AP, Dr. Ram Gopal Chejraj. When the first program was rolled out, just I was wondering how Raigad branch and MAHA-AP first thought about rolling out in a journal journey, how it is going to be useful to the practicing pediatrician. Initially, we thought the journal club means it is for the postgraduate, it is for the teacher. But when the things started in the 2021 with Bhandarkar sir, Chitra Kulkarni madam, Amul, Hemant Gangolia sir, of course, subsequently well supported by Dr. Neha, things were really, it was one of the most popular program introduced by the MAHA-AP, which is not only making the practicing pediatrician to change their way of thinking towards a journal, and also implementing it in the clinical practice. I am fortunate on first day in the office, I have been here for a journal club. That's one of the things. So today afternoon only we rolled out a national treatment guidelines in emergency medicine and the toxicology. Dr. Meena Sheikh was spearheading that along with Dr. Harun Bansal, Dr. Sunit Singhi, and many of the stalwarts of any critical care, where they are coming, rolling out in every week national treatment guidelines for the emergency and the toxicology. So that's going to be the benchmark of an Indian Academy of Pediatrics. Along with this program, really I am appreciate the Raigad IAP, Dr. Swati Madam, and today's expert, Dr. Atul Kanikar sir and Dr. Vishnu Biredar. Of course, two young Turk, Rajashri and Purvi. So really, I am sure this is the things which is going to be given a lot of insight into the what really the practicing pediatrician needs to know. And the final comments from Vishnu Biredar, who is known for crisp and clarity in his presentation and a more practical oriented person. Dr. Atul Kanikar sir is always there, is editing the books and academic work for decades. Sir was the, I'm sure today's things is going to benefit our practicing pediatricians too. With these few words, wish you all the best, Ram Gopal and our dynamic secretary. So our another mitochondria at the national AAP is Amul Pawar. So he is infecting not only the Maharashtra, now he is infecting all over India with the dynamism. The quickness he delivers the work is something amazing. In the history of Indian Academy of Pediatrics, on the first day in the office, if the program has been rolled out, thanks to our action plan team led by Dr. Knanmurthy, Dr. Amul, and Dr. Nandish, really all the three has been in the first in the history of Indian Academy of Pediatrics, first day itself, all the program has been allotted to the branches. Sufficient time has been given to conduct the program at the district level. All these things is possible. The people like Dr. Amul, wish you all the best. So more tribes of this type of things will come and emerge to take the academic in a mission mode to the practicing pediatrician across the India. I request, this is also one initiative like similar to that. So I'm sure our members will be benefited, and not only taking IAP to the academics, to the nook and corner, and also to the community. That is another thing we will be rolling out shortly, that program also. With this, once again, thank you for inviting me to share the first official platform, that to a Raigad and Maha AP. It's almost like my home branch and home state. So thank you very much. Thank you very much, Dr. Swati Madam. Thank you, Chitra Madam and Neha, for inviting me. Thank you.
Thank you so much, sir, for your encouraging words. And now I call upon Raigad IIP President Dr. Vikas More, sir, to welcome the dignitaries and introduce guest of honor, Dr. Vasant Khalatkar, sir. Over to Dr. Vikas.
Yeah. Because sir, Vasant has not joined yet.
Okay.
Yeah. Okay, fine. I will just give a
Yes.
introduction. Good evening, everyone. I am Dr. Vikas More, President IIP Raigad. It is such a fortune that I am heading a team full of very enthusiastic IIP members like Chitra Madam, Gangulia sir, Dr. Mahesh Mohite sir, Dr. Dabadkar sir. So IIP Raigad, though is a small branch, but we have many stalwarts who are so much interested in academics. As we grow in the practice, we generally start getting dependent on the experience-based learning. But the only focus of starting this journal journey is to have a balance between experience plus evidence-based learning. It will definitely affect the health of our kids. Now, as we know that I'm so grateful that our dear President Dr. G. Basavaja has, on the first day of his taking charge as a president, he is addressing us. It is such a fortune. Thank you so much, sir. Vasant Khalatkar sir is the president-elect National IIP. We know him. He's our own from Nagpur, and even he had joined. I know on the first day of immediately after he got elected, he also joined our CME. So Raigad IIP has a fortune of getting the presidents on the day one of their work. So we are so fortunate. And experts like Dr. Atul Kanikar sir from Nasik, and my best friend Dr. Vishnu Biradar, the pediatric gastroenterologist from Jupiter Hospital, Baner, Pune. They are our experts, and I am so much grateful to them. And Dr. Purva Jain is our own IIP Raigad member, and Dr. Rajeshri Rajurkar from Pune. Again, these two topics are very important because whenever we talk about pancreatitis in children, the general pediatricians very much scared about that. They feel that they can't manage it. They even don't go into that. They immediately refer the child. So today's paper will definitely give us insight how to have an approach the patients with pancreatitis and at what time you can refer them. And the second is very interesting topic like brain networks and adolescent alcohol use is again another upcoming topic because our kids are now getting involved in different substance abuses. So we need to have this more understanding about this topic. So I am very much excited for these two topics. Again, I welcome all of you, and especially I thankful to Ram Gopal sir that he extended the Zoom capacity to 500 members because every time we are crossing 100 attendance, I am so much thankful that he again allowed to continue this program in 2024. And I have no words to thank Dr. Amol Pawar, Dr. Jitendra Gawane, who are always behind Raigad IIP for all these activities. And Dr. Hemant Gangulia sir, Dr. Jay Bhandakar sir, Dr. Chitra Kulkarni madam, and most importantly our fatherly figure, Dr. Niman Mohanty, who is such a bless to IIP Raigad, who due to whom we can conduct this activity. And at the end, Dr. Swati Likhite madam, thank you so much for moderating session so beautifully. Over to you, madam.
Thank you, Dr. Vikas. And I guess as Dr. Vasant Khalatkar sir is traveling, I don't think he'll be able to give the blessings, or is he online?
No.
He's not online.
I
Okay.
think he has just joined. Chitra madam, he has just joined.
Yeah,
Vasant sir, yes.
Okay. So I request Dr.
Vasant,
Vasant Khalatkar sir
yeah.
to give the blessings.
Welcome,
Thank you,
Dr.
sir.
Vasant ji. First official program.
Good evening. Just landed from Mumbai. I think and will say all the best for that because I may not be audible. So just landed at the Mumbai. Thank you, and this journey should go on. Okay,
Thank you.
Thank
Thank
you,
you,
sir.
Dr. Vasant Khalatkar, sir, for your wishes. Now I request Dr. Jay Bhandarkar, sir, to introduce our first expert of the day, Dr. Atul Kanikar, sir,
Madam,
adolescent expert.
Dr. Swati, madam, 1 minute. If Nimen Mohanty sir is there, this is the first day. Probably we can ask Mohanty sir to say 2 or 3 lines, please, if he is there.
Yes.
Dr. Mohanty, sir, are you there? Have you joined?
I had not seen him.
Okay.
No,
And
he has not
yeah,
joined.
and on for both the topics, he is going to give his expert comments.
Okay. Okay. So I request Dr. Jay Bhandarkar, sir, to introduce our first expert, Dr. Atul Kanikar, sir, who is an adolescent expert, and then our first speaker of the day, Dr. Rajeshri Rajurkar, and her topic is brain network and adolescents alcohol use. So over to Dr. Jay.
Good evening to all. At the outset, Happy New Year to all of you. And I will say the visionary President Basavaraja sir is joined for today's activity, but I will attach another word, machinery President, so that we are going on and on our activity. So I have a privilege to introduce our first expert, Dr. Atul Kanikar sir. He's a child and adolescent care practitioner of Nashik and is author of the book From Terrible to Terrific Teens, and is a counselor of childhood, teenage, and behavioral problems last 18 years. About 350 parenting workshops, more than 600 school college programs in family life education, pre-marital counseling, and almost 40 innovative workshops for teachers, students, and others. He is a faculty at the national and various national and international conferences of the IIP. Author of in many UG book, textbook, postgraduate textbook of the pediatrics, IGP is a practical journal pediatrics, and many modules on adolescent health. Welcome, sir. Thank you for joining today. Our first speaker is young dynamic Dr. Rajeshri Rajurkar. She is currently senior resident at the Kashibai Navle Medical College, Pune. Till present is a senior resident in the pediatrics, Gandhi Medical College, Bhopal, Madhya Pradesh. And she's MD done from the Sri Aurobindo Medical College, Indore. So welcome, Dr. Rajeshri, and thank you for joining for today's Journey Journal. Over to Swati again. Thank you.
Thank you, sir. And I request Dr. Rajeshri to share her slides and start the presentation.
Good evening, everyone.
What's on here?
Good evening, everyone. My topic is brain network and adolescent alcohol use. So, this article was published in Journal of American Medical Association, published on 11th November 2023. These are the authors. The importance of article is, as alcohol misuse in adolescence is associated with higher risk of alcohol use disorder. So, by identification of the brain mechanism underlying the risk for alcohol misuse, will help in prevention and intervention of alcohol use disorder. Adolescence is the critical time for transition from alcohol misuse to alcohol use disorder due to ongoing brain development during this time. So, this period is therefore considered an essential point for identification of brain circuits contributing to problem later in life. By identifying the brain mechanism associated with early risk, this study aim is to develop intervention approaches that help to decrease the problematic alcohol use. Contemporary theories of alcohol use risk emphasizes the role of inhibitory system, the prefrontal cortical structure, and reward system involving the subcortical structure. Sex differences in alcohol use during adolescence is also reported. This study aimed to identify the neural network conferring the possibility for alcohol use in adolescents with specific consideration in the sex differences. Neuroimaging data were required during the performance of different cognitive tasks relevant to the current neurodevelopmental model. The tasks were the reward processing task and inhibitory control task. They anticipated that network identified during the reward-related process would be more relevant for predicting the alcohol use behavior in the younger adolescents, and that network identified during the inhibitory-related process would be most relevant for predicting the alcohol use behavior in older adolescents. Methods: alcohol use and neuroimaging data was collected by the Imaging Consortium. Imaging Consortium is a European project examining how the different factors during the adolescent may influence the brain development and mental health, and they do it by the neuroimaging. So this data was taken across the 8 sites. Ethics committee of each site approved the study. A parent and guardian provided a written consent, and adolescent provide a verbal assent. Baseline data acquired at the age of 14 years and follow-up data were taken at the age of 19 years.
Yes, doctor.
मैम एक्चुअली हैंग हो गया ये
नहीं, उसको डबल टैप कीजिए, डबल टैप करके देखो, डबल टैप करके देखो स्लाइड पे, कर्सर से डबल टैप कीजिए आप वो स्लाइड पे ना, कर्सर से आप डबल टैप कीजिए, मूव होगा।
स्लाइड तो नहीं,
स्लाइड पे आप कर्सर से डबल टैप कीजिए। हाँ, इस पे अभी डबल टैप, हाँ जाएगा, हाँ यस डन, गो अहेड, गो अहेड, हाँ।
yes. Baseline data acquired at the age of 14 years and follow-up data acquired at the age of 19 years. Analysis focused on predicting the alcohol use risk at age of 19 years. Data acquired at the baseline, that is at 14 years, were used to identify the network associated with the future alcohol use risk. And data acquired at follow-up at 19 years were used to identify the network associated with the current alcohol use risk. Neuroimaging data were processed using the connectomes. Connectomes provide a multivariate summary of individuals' unique pattern of functional brain organization. Analysis focus on connectomes derived from the neuroimaging data acquired during the both reward and inhibitory tasks. Connectomes were entered into the connectome-based predictive model to identify the network associated with the alcohol misuse. So in a connectome-based predictive model, connectome associated with the alcohol use severity are identified. They then summed up to create a model. That model is applied to the novel connectome to generate a behavior prediction. Alcohol use was assessed during using the alcohol use disorder identification test audit. It is a well-validated, self-declared data of alcohol use risk with total score ranging from 0 to 40. Audit score at the age of 14 years were low, and at the age of 19 years it was high. So audit score was significantly increasing from the age 14 to 19 years. Neuroimaging was done where functional MRI data was collected using reward task and during the inhibitory control task. Both brain connectomes were computed using the Sheen Atlas. Sheen Atlas has 268 regions into the 8 networks. 268 regions here are showed as a 268 nodes, and node by node pairwise connectivity correlation was computed using the mean time course. Connectome were then entered into the connectome-based predictive model analysis predicting score at 19 years of age on audit to identify the model associated with the future alcohol use severity and current alcohol use severity. Finally, the model features were directly mapped back to the neuroanatomy to provide a mechanistic insight. Network anatomy and virtual listening was done. The anatomy of the network associated with the alcohol use risk was identified via the spatial overlap with a large-scale neural network. Further, to maximize the mechanistic side, post-hoc virtual listening approach was used, in which the connection overlapping with all but single canonical network were virtually lesion. Canonical network are the septal overlap with a large-scale neural network. So on the results, among the 1,359 individuals in the study, the mean age was 14.42 years, out of which 729 individuals were female. On neural network associated with the future alcohol risk, on the analysis of baseline data at 14 years, found a sex divergence in predictive accuracy of connectome-based predictive model assessing future alcohol use severity. Specific a sex agonistic model and female-only model were successful in predicting the future alcohol risk severity, but male-only models were not. But on analysis of follow-up data at 19 years for current alcohol risk, it further indicated a sex divergence in predictive accuracy of CPMs assessing current alcohol use severity. Specifically, both sex agonistic model and female-only model were successful in predicting the current severity across both the task type, in contrast to the male-only model, which is successful in predicting the current severity acquired during the inhibitory task performance, but not using the data during the reward task performance. This is the table showing the population used, in which the total number of sample used is 1,359, out of which 729 were females. The mean age is 14.42. Here we can also see the audit total score, which was at the age of 14 years were 1.20 and audit score at 19 years was 5.76, which increases from the 14 to 19 years. Anatomy of alcohol risk network. Anatomy is summarized separately for the positive and negative predictive connection. Positive predictive connection are those for which increased connectivity positively predicted the alcohol use risk, and negative predictive connection are those for which decreased connectivity positively predicted the alcohol use risk. So, on neural network associated with future use alcohol risk, here the female-only future use severity network was identified in both inhibitory and reward tasks, which show strong positive connection included in within the network of medial frontal, motor sensory and cerebellar connection, between the network connection with cerebellar and subcortical connection. A network identified during the reward data showed strongly positive between the medial frontal and motor sensory. And for both tasks, the negative connection includes network within the motor sensory connection. So in this figure, anatomy and virtual listening of future severity network, the graph with the red one is showing the positive connection, and with the blue one is showing the negative connection. In this, the dark line showing the strong connection. So for the female only future severity in the reward task data, we show the strong positive connection in the medial frontal, cerebellar, and in the negative connection for the reward, we can see strong positive in the motor sensory. Similarly, for the female only future severity risk identified for the inhibitory control task data, Here, the strongly positive shown in the subcortical and cerebellar, between the subcortical and cerebellum. And for the negative connection data showing between the motor sensory connection. And further, this is the post hoc model. In the post hoc model, we can see for the reward task data, it is showing strongly connection in the frontal parietal, motor sensory, salience and cerebellum. And for the inhibitory control task data in the motor sensory, cerebellum and salience. For the female-only positive network generated using inhibitory and reward task data was dominated by motor sensory connection, salience connection, and subcortical connection. Negative network were largely characterized to the motor sensory, salience, and subcortical. And for the male-only current severity risk, network identified during the inhibitory control data. So positive is dominated by connection between the cerebellar and subcortical network within cerebellar network. Negative is dominated by cerebellar, subcortical, salience, and medial frontal connection. This study identified the neural network associated with the alcohol use risk using an advanced connectome-based approach. Both common and distinct neurobiological substrate of early alcohol use risk among the female and male adolescents were identified. For the female adolescents, model generated using neuroimaging data from both task type were successful in identifying the reliable neural signature for future and current alcohol use risk. And for the male adolescent, only the model generated using the inhibitory control task data was successful in predicting the current alcohol use risk. No reliable signature for the future risk was identified. Medial frontal and salience network were primarily associated with the future alcohol use risk, whereas the cerebellar and motor sensory network emerged as a primarily associated with current alcohol use risk. These data suggest that targeting the prefrontal cortical region may be particularly relevant for prevention effort in younger adolescents, and that targeting a cerebellar and motor sensory region may be more relevant for intervention effort in older adolescents who have already been initiated drinking. So conclusion, this data provide a connectome-wide assessment for neural networks observing alcohol use risk and identify a dimensional network for alcohol use risk in adolescents. These data suggest that intervention using the inhibitory control process may be effective in combating alcohol use risk in male adolescents, but both inhibitory and reward-related process are likely of relevance of alcohol use behavior in a female adolescents. They further identify the novel network for alcohol use risk in a youth, which may be used to identify the adolescents who are at risk to inform the intervention efforts. Thank you.
Yeah.
Thank you, Dr. Rajeshri. It was really crisp and informative presentation, and she has told us about the neural network associated with the alcohol use risk. And we are all eager to listen to the comments by our expert, Dr. Atul sir. So over to you, sir.
Namaskar.
Namaste, sir.
Rajeshri madam, many congratulations for
Thank you,
this quite technical sort of research, I would say, which points to the fact that the males are very tricky and they are very difficult to control, as they grow old. Whereas you can do a lot about female drinkers who are more than 55-58% in the early age. What I wish to ask you is, you have been moving from Indore to Madhya Pradesh, Bhopal, and then now, I don't know where you are, Raigad maybe. So it's a wonderful journey of yours. What I wish to ask you is, what is your opinion about the craft assessment for alcoholism?
This graph are actually meant for finding the regions for the regions which are responsible for the alcohol misuse in the future. For the
No. Have you heard of the Kraft scale? CRAFT. Kraft. About alcohol use. It's one of the scales where you can assess the actual risk, what we do in our teenage practice. But that is a very good pointer towards. It includes so many parameters that have you been riding a car or a bike under effect of alcohol? Were you with someone on a bike or in a car who was under effect of alcohol, and were you involved in some antisocial activities when under influence of alcohol? And so many things. Whether your family and friends have told you to stop down, to curtail all your alcohol. So they are very practical things. There is something also called as Kraft N now, which applies to craft and nicotine. I mean, alcohol and nicotine abuse. What we have learned is nowhere there is a mention about the limbic system and prefrontal cortex connection in your whatever literature that you put.
Yes, sir.
And that maturation process starts at around 17 years, continues till 24 years. And what bothers me, again, it's up to you to elaborate it and enlighten us on, is the changing social media, the film exposures, and the peer group, and opportunities for young people to engage in alcohol and other substance abuses. So, what are your comments on this, if you can tell me? Let us talk practical. I mean, all this only girls, only boys, all these classification, blue, pink, and all that, it's fantastic. It's above my head. I don't read that much. But what bothers me is this particular 2024 culture, the celebration, the birthday celebrations of our teenagers is now in the vineyards and restaurants with parties and all that. There are night outs and sleepovers and God knows what. हमारे ज़माने में ऐसा नहीं था, हम बुढ़े हो चुके हैं. But the thing is, Rajeshri madam, what are your comments when it comes to prevention? You are talking about so many scales and these things, but what are practical things that you would recommend us as practicing pediatricians? Because this whole process of whatever journey is about practicing pediatricians. So what are your recommendations to us?
Yes, sir. You have rightly pointed it out that it has become a social norm, and our paper is to increase the awareness about these issues. And when an adolescent walks inside your OPD, according to adolescent expert, Dr. R.N. Sharma sir is also here, we have to take that Hades history properly and give a special point to ask about the alcohol use also.
Who is going to admit, madam? Can you ask?
Not admitting, but the awareness in pediatrician also has to be increased.
What respected Rajeshri madam mentioned was the average age is 14.9. Is that so? The mean age. Rajeshri madam, I'm talking to you.
Yes, sir.
It's 14.9.
14.
So, if you ask a 14-year or 15-year-old girl or a boy, and that too in front of parents, because parents are very inquisitive that time, which child is going to say, yes, I have tried and I consume alcohol? No one. If I was a teenager at 14 and 15, I would actually slap such a pediatrician who asked me the question.
Sir, actually the data is not from Indian data, it is European data.
I understand that. Looking at your blue and red and pink and whatever colors of shade. But
sir has shown the Indian side also. He just said that
what I'm
parties
talking,
is in
Chitra
vineyard.
madam, what I'm talking, Chitra madam, is the practicality of this particular journal article that Rajeshri madam has tried to talk about. So what are your recommendations, Rajeshri Madam? I am all ears. What do you say? What do you suggest to us as stupid practicing pediatricians faced by such high risk taking teen behaviors in our day-to-day practice, where the parents look with a lot of hope in their eyes towards us, and we are not actually equipped to deal with the issues? What are your recommendations? Our own children could be in that age group. So, as an academician, as a person doing research and all these things, what are your recommendations? Or anybody on the screen can enlighten me on this.
Can I say, Dr. Chitra Madam?
Yes.
If Dr. Arun Sharma is there, if he is there,
Yes.
if presenter
And
is not
along
unable-
with that, our pediatric neurologist, Dr. Chandana Bhagwat, is also here, and
they
she
can
is
say
supposed to
something.
comment for the neuronal networks and alcoholism in adolescents. Dr.
So
Chandana,
whatever-
please. Yes, ma'am. Please unmute. Not able to unmute?
Pallavi Madam?
Pallavi, ma'am?
Yes, sir. Yes, sir.
Yeah.
Ma'am can unmute
Please
now.
unmute Dr. Chandana.
Yes, she can unmute now.
Yeah.
So, good evening, all the dignitaries. And Atul sir, so I do not have the answer to your question that what we should do in such setting when such adolescents come. This is predominantly a European study. So, but the point that I wanted to highlight is that they have recruited adolescents at 14 years of age. They have not mentioned that the adolescents started drinking at that age. So the median age that they have mentioned, I'm not sure whether it is the initiation of the drinking or the median age of adolescent that they have recruited in the study. And secondly, the utility of this study. So utility of this study is that we can try targeting the prefrontal cortexes in the early adolescent age group. So with the help of drugs or with the help of behavioral therapies, and we can try targeting the cerebellar and the sensory motor networks in the later adolescence. However, in our Indian setting, with this amount of social issues, that how can we ask a 14-15-year-old adolescent walking in our clinic whether he has alcoholic issues or not? I also do not have a sufficient answer. I think the seniors will be able to help with this, sir.
Actually, what I'm sure Chitra Kulkarni Madam is doing the same thing. There are Maharashtrians here. We can talk in Marathi. बोलू शकतो आपण. हे सगळे गेले का? इडली डोसे वडे.
Sir, this is a Maharashtra IAP program. You can very well speak in Marathi.
So जेव्हा आपण भेटतो या मुलांना, if anybody doesn't understand Marathi, please let me know. What we do is तुला काही सवयी आहेत का विचारण्याच्या आधी तुझ्या मित्र-मैत्रिणींना काही सवयी आहेत का? That is number one. Second thing is, have you ever been forced or pushed by any of your peer groups to try this, try that, whether it is nicotine, whether it is vodka, whether it is alcohol, beer, champagne, whatever, wine, that is the usual starting drug nowadays. And third thing is, has anyone taught you how to say no? And we take this in our so-called anticipatory guidance in our teenage clinic. So we immediately can pick up the child who is at risk. And our aim is in prevention, whether it is drug abuse, whether it is rash driving, whether it is sexual experimentation, anything. So prevention, our role as practicing pediatrician is tremendous, and we have to focus on that. So I would be very glad if at the end of, I'm quite proud to have you all here and conduct this program for last so many years, and then wish to continue in the next year also. But at the end of each program, each session, we have to have some take-home message, practical, doable things in our pediatric practice. That is what I would recommend. But this study was fantastic, and congratulations to the presentations of Rajeshri Madam, well guided by Chandana Madam. I am quite glad that we are actually inculcating these foreign German or US or whatever studies. But the aim is to have some take-home message which is doable, which is practical, which is possible for a general public, whether it is in Raigad or Sangli or Satana. Amol Pawar sir is from Satana, or Nashik or Mumbai, wherever, doesn't matter. But it has to be having some practical guidelines at the end. That is what I believe. But many congratulations, Rajeshri Madam and Chandana Madam and all of us. Yes, please, sir.
Yeah, Vishnu sir.
Yeah, and along with that, I think we should be always talking about the sex education also, and the direct questioning for the sex abuse, because these are the children goes into the alcohol or nicotine or the substance abuse when there is a history of strong sexual abuse. And
So
one
that
of
is
the
what it boils down to life skills. When you teach how to say no, it applies to everything. Okay.
Yeah.
It applies
Yeah,
to
Gangolia
everything.
sir. Yeah.
No, what Dr. Atul Kanikar sir said now, exactly that was the objective when we started the journal reading. At the end of the session, we should have take-home messages. Therefore, probably some schedule was drafted, which I may post in 1 or 2 days. Actually, the selection of the presenters according to the articles and experts should be done pre-hand. So, as per the rehearsal also, that time also involving experts, we can have a good take-home message at the end of the session. At the 11th hour to do all the things will maybe not be possible. So we will make crystallize. Ultimately, we have to get a take-home message which is useful and doable by the general practitioner, pediatrician in their practice. So we will definitely, this was the aim actually, but somewhere we lost the way in between because maybe there's some reasons, but we will try to rectify it and may go in that way. Thank you very much.
Minaj sir.
Yeah, thank you. I was listening to all, but I must say there are a couple of objectives of journal. One is the acquiring evidence. Second is, does this journal will change my practice? So I must say, in objective number 1, no matter whatever time Dr. Rajeshri has, has got to prepare, she has done fantastic job. We must applaud, because it was a complex topic, a very complex study, and the way she has narrated, it is really, I must say, it's a difficult topic. So that objective number 1 has been entirely fulfilled. At the same time, as Atul sir is telling, that does this change my practice? I agree that Atul sir, we belongs to the previous generation, but please understand that our generation, the next generation is changing also, and people are opening at the age of 13, 14 years also. It all depends upon, we have a variable heterogeneous population. So some people, some strata are opening up also. So in the due course of time, probably we may be getting people are opening up. It's only that we have to train ourselves. And I must say, this one step, what Rajeshri has done, is a step towards that training also. So in future, such articles, such presentation definitely will change our practice also. This is my take for this particular. Heartiest congratulations to the presenter. It was a complex topic. It is extremely good. My take for this. Thank you for the patient sharing.
Thank you. Shall we move to the second topic now?
Yes, madam.
Monty sir is there, ma'am.
Yeah, Monty sir, he said he will like to let the expert comment, he said.
I will
Monty
speak
sir.
in the end. I will say only one word I want to say on this topic is, this topic is doable in our setting. Although it's a European study, this is a very scientific study. It is documented objectively in a pictorial form. Which area is involved? By the time we detect this child has become alcoholic, it is too late to intervene. That time is very too late. If we know these particular areas where to intervene, I think that the job is done, to the message goes to them. Suppose you detect a person, which area to target, which drugs you have to choose, that is the aim of this study. Number two, my submission is journal article. We are not discussing the journal aspect of this issue. The study, the objective has been covered, which exact methodology they have taken, and the result. Our discussion has to confine to these aspects only within the topic. So there are so many things which can be said and can be discussed also, but we have to confine our discussion to the objective. If the objective has been selected to the research question, related question, and the objective has been fulfilled in the methodology, and the actual results have been brought out, and the inference drawn is actually based on purely on the results. This has to be seen and the message conveyed. I think this job is done. This topic was given to her in the last moment, only hardly 3-4 days was left. We are not able to identify people who do not volunteer. It has been thrust upon this lady. She is good of her, she accepted it and prepared it in such a short time. And this was told to her, and now things have happened like this. I think she has done the job, sir. Everybody has applauded her. I also congratulate her. Thank you.
I agree with you, sir. Totally agree.
Thank you so much, sir. I really thank everyone for everyone's insights. Dr. Chandana, Dr. Atul sir, Dr. Gangolia sir, Dr. Sheikh sir, and Dr. Mohanty sir. So let us move to the second topic of the day. Now for that, I invite
Swati ma'am, please 1 minute. Thank you, Atul sir, for joining. In spite you were ill, you have to taken medicines and then joined.
Amol sir.
Thank you from Team MAHAAP.
Thank you, sir. Dhanyavad.
Yes, sir. If you want, you can leave, sir. Please. Thank you.
Yes, thank you, sir. Thank you so much. Thank you. Bye.
Swati ma'am, please continue.
Yeah. So moving to our next topic, I would like to invite Raigad IIP President Dr. Vikas More sir for introducing our second expert for the day, Dr. Vishnu Biradar sir, who is a pediatric gastrohepatologist at Pune and Navi Mumbai, and also to introduce our second speaker, Dr. Purva Jain, for the day, who is Associate Professor at MGM Medical College. And her topic is pancreatitis in children. So over to you. Dr. Vikas.
Please introduce.
Dr. Jay, introduce. Dr. Jay, introduce.
Okay. Thank you, Swati. So our second expert, Dr. Vishnu Biradar, actually doesn't need any introduction, but I will do the formality. He's a concerned pediatric gastroenterologist and hepatologist. Present, he's working in Jupiter Hospital, Baner, Pune, as well as doing his own Kamal Endoscopy Center, Shivajinagar. And he's a Isfahan International Travel Exchange Award in 1819, awarded many papers, posters, publication, national and international platforms. And he's a pediatric liver transplant, done fellowship in pediatric liver transplant in the UK. Thank you, Swati.
Okay, thank you, sir. And over to you, Dr. Purva.
So, Dr. Purva is introduction द्यायचंय का नाही द्यायचं?
हाँ, introduction द्यायचंय.
Okay.
No, Vikas is there.
Dr. Purva Jain is an assistant professor in Department of Pediatrics, MGM College, Kamote, Mumbai. He's a consultant pediatrician hepatologist, working in the Ratnaj Clinic and Nursing Home of the Karzad, as well as at Panvel. And he's working at the MediSecure Super Specialty Hospital, Nursing Home in Kamote. Welcome, Purva is from our own Raigad IIP member. Thank you.
हम जैन भाई का बहू है ये.
Dr. Mohanty sir met Dr. P.B. Jain sir of Karzat, very senior pediatrician, a patron of IIP Raigad. त्यांची सुनबाई आहे Dr. Purva Jain.
Yeah.
Welcome, Dr. Purva.
Yes, ma'am. Good evening. Wishing you all a very happy new year. Good evening to all the dignitaries and my dear friends. So my topic is for the today's is pancreatitis in children. It's a review article from North American Journal for Pediatric Gastroenterology. And author is Cohen and Freeman. It's volume 68, issue 6. Introduction and definitions. This journal review of pediatric pancreatitis is organized over this spectrum of acute pancreatitis, acute recurrent pancreatitis, and finally chronic pancreatitis. Acute pancreatitis, it should have at least 2 findings: abdominal pain consistent with acute pancreatitis, amylase or lipase is equal to or more than 3 upper limit of normal, imaging consistent with acute pancreatitis. Acute recurrent pancreatitis is more than 2 episodes of acute pancreatitis, resolution of pain or amylase or lipase between the episodes of acute pancreatitis of 1 month gap. Chronic pancreatitis should have at least 1 finding: abdominal pain consistent with pancreatic origin and imaging suggestive of chronic pancreatic damage, or evidence of exocrine pancreatic insufficiency and suggestive of pancreatic imaging findings, or evidence of endocrine pancreatic insufficiency and suggestive pancreatic imaging findings. Let's start with the acute pancreatitis spectrum and management. The incidence of acute pancreatitis is 13 per 1 lakh children with rising rate of diagnosis. Lipase is more accurate diagnostic marker of acute pancreatitis, particularly in infants. First-line imaging for suspicion of acute pancreatitis is transabdominal ultrasound, which has the added benefit of diagnosing biliary obstruction and identifying pancreatic fluid collection and abnormal pancreaticobiliary anatomy. Etiology, coming to the etiology and risk factor, it differs from the pediatric as well as from the adult. Even within the childhood, there is a risk factor has been changed from infancy through toddlerhood and adolescence. In infancy and toddlerhood, etiology is towards trauma, systemic disease, and inborn error of metabolism. Where in contrast to adolescence, it's more caused by biliary disease, medication, or idiopathic. So this is a 2 comparison showing the first A is a pediatric and B is for the adult. Pediatric biliary anatomic, most common, medication, idiopathic, systemic disease, trauma, viral, post-viral, others, and metabolic. While in the adult, alcohol is the most commonest, followed by biliary anatomy. These are the specific risk factors for pediatric acute pancreatitis. Most common biliary or anatomic: choledocholithiasis, pancreas divisum, pancreaticobiliary malfunction, choledochal cyst, annular pancreas, intestinal duplication. Medications like valproic acid, prednisolone, trimethoprim sulfamethoxazole, tetracycline. Systemic disease: autoimmune pancreatitis, sepsis, lupus, HSP, Kawasaki disease, inflammatory bowel disease, and HUS. Trauma: genetic inborn error of metabolism, metabolic diabetic ketoacidosis, hypertriglyceridemia, hypercalcemia, and chronic renal failure. This is a ranging severity of acute pancreatitis from mild to severe. Mild acute pancreatitis is absence of organ failure, absence of local or systemic complication. Usually it resolves within a week. Moderately, there's a transient organ failure that resolves within 48 hours associated with local complication. While in severe acute pancreatitis, organ failure that persists for more than 48 hours. Management of acute pancreatitis has 4 domains: fluid resuscitation, end organ monitoring, and prevention of progression to severe pancreatitis, early nutrition, and pain control. So these are the 4 domains. Aggressive fluid resuscitation is in the form of crystalloid, more commonly used ringer lactate RL, 10 to 20 ml per kg bolus, followed by maintenance. We have to monitor vital signs and urine output, followed by end organ monitoring. We have to do end organ monitoring as we are giving boluses. So to see about the kidney damage or a pulmonary edema. So we have to monitor vital signs, urine output, BUN, and creatinine. Early nutrition is a hallmark, all oral or enteral nutrition within 48 hours, no dietary restrictions, pain control, scheduled at NSAIDs, opioids as needed. Nutritional management in acute pancreatitis. Conventionally, wisdom was NPO. Approach to management of acute pancreatitis is an effort to presumptively suppress pancreatic enzyme production. However, NPO status has been associated with increased risk of translocation of bacterial flora from the gut, causing increased morbidity in acute severe pancreatitis. Early introduction of oral or enteral nutrition is associated with decreased length of hospitalization and does not result in worsening of abdominal pain. So if we have to start early nutrition in less than 48 hours. If it is intolerant, we place a nasogastric tube for enteral nutrition, followed by nasojejunal administration. And if it is not tolerated for a week, we start a parenteral nutrition. Advanced endoscopic intervention in acute pancreatitis. Biliary obstruction is the most prevalent risk factor of pediatric acute pancreatitis, and clues the etiology are often in the form of elevated transaminase, bilirubin, and gamma-glutamyl transferase. Ultrasound is typically an insensitive diagnostic tool for an identification of a common bile duct stone and cross-sectional imaging, while MRCP must be obtained. In the case of biliary pancreatitis, endoscopy, ERCP, endoscopic retrograde cholangiopancreatography should be pursued within 48 hours. If the patient has an obstructive jaundice or cholangitis, should be followed by same admission with cholecystectomy. Management of pancreatic fluid collection and pancreatic duct trauma. So the local complication for acute pancreatitis is acute pancreatic fluid collection, acute necrotic collection, pseudocyst, and walled-off necrosis. These are characteristic in revised Atlanta classification, and we'll be showing in the next slide. So these are the 4 types of classification. Acute pancreatic fluid collection develops in early phase of pancreatitis, lack a well-defined walled, homogeneous, confined by facial planes, maybe multiple, sterile, and resolve spontaneously. But if it is localized fluid collection of more than 4 weeks, it converts into pseudocyst, which has an increased amylase with fluid, often arise from disruption of pancreatic duct, and it's rare in acute pancreatitis. Well, the same case in acute necrotic collection, it arises from necrotizing pancreatitis. Fluid and necrotic pancreatic parenchyma or peripancreatic tissue in the first 4 weeks of development may be loculated, can be infected, which leads to walled-off necrosis if it's more than 4 weeks after necrotizing pancreatic onset. It's a mature encapsulated collection of pancreatic necrosis with a well-defined inflammatory wall, and it can be infected. So this is endoscopic use for the utility for pediatric pancreaticobiliary disease. For diagnostic purpose, we use for pancreatic parenchymal anatomy, cystic pancreatic lesion, autoimmune pancreatitis, suspected choroidicolithiasis, unknown etiology of obstructive jaundice, pancreatic mass fine needle aspiration. For therapeutic cystogastrostomy, which is very important procedure, celiac, which is used for drainage of a pseudocyst. Celiac plexus neurolysis, biliary damage if unable to access papilla. Antibiotic administration in acute pancreatitis. Adult and pediatric guidelines do not recommend routine prophylactic antibiotic use in acute pancreatitis, even in severe cases, unless there is an evidence of infected necrotizing pancreatitis or a patient with necrosis who are not improving with antibiotics is the only indication to start an antibiotics. Then coming to autoimmune pancreatitis, it's a very rare entity, accounts only for 4% of pediatric pancreatitis. It's most prevalent in adolescents and presents with typical abdominal pain and often with direct hyperbilirubinemia and a history of weight loss. In contrast to autoimmune pancreatitis, in contrast to acute pancreatitis, autoimmune often presents with normal serum amylase and lipase, leading to a broader differential diagnosis that includes a host to pancreatic biliary pathologies and requiring the supplementary radiological and histological information. And these are of 2 types, type 1 and type 2. Then coming to acute recurrent pancreatitis, approximately 1/4 of acute pancreatitis develop with acute recurrent pancreatitis. Acute recurrent pancreatitis warrants expanded evaluation given the higher prevalence of genetic, anatomic, and metabolic risk factor. Genetic testing should be undertaken when children present with acute recurrent pancreatitis. In chronic pancreatitis, the likelihood of identifying a genetic risk factor is even higher, further supporting the need for a genetic evaluation. Identification of a gain of a function PRES1 mutation is particularly important in that there is a higher penetration and resulting increased probability of progression to chronic pancreatitis and possibly to pancreatic cancer. So these are the 4 most commonly genetic risk factors: CFTR gene, PRES1, SPINK1, and CTRF gene. Imaging in acute recurrent pancreatitis. In addition to the imaging, investigation delineated in acute pancreatitis, additionally cross-sectional imaging with MRCP, and if available, our gut hormone secretin enhancement to better delineate subtle pancreatic ductal abnormality should be pursued in ARP. Secretin administration not only provides increased detail regarding the anatomy of the pancreatic duct, but also help to elucidate pancreatic outflow dynamic concomitantly. Then coming to the PERT therapy, it's a pancreatic enzyme supplementation is used in acute recurrent pancreatitis as well as in a chronic pancreatitis as a treatment for a pain in initially appealing because of a theoretical and negative feedback regulation of pancreatic enzymes. Coming to chronic pancreatitis manifests with irreversible fibrosis and pathological changes to the pancreatic parenchyma and pancreatic duct abnormalities, which are evident radiographically with characteristic pancreatic calcification or pancreatic duct morphologic abnormalities. The diagnosis should include clinical findings of the abdominal pain consistent with pancreatitis, evidence of exocrine pancreatic insufficiency, or evidence of endocrine pancreatic insufficiency. A pancreatic biopsy demonstrating a histological evidence of chronic pancreatitis is sufficiently diagnostic. Characteristic, so cross-sectional imaging in children with chronic pancreatitis can identify calcification, atrophy, and inflammatory changes of suggestive chronic pancreatitis. Additionally, most children diagnosed with undergo MRCP, which can characteristically demonstrate morphological abnormalities of main pancreatic duct and side branches, intraductal calculi, stenosis, strictures, and peripancreatic fluid collection. ERCP can better elucidate ductal changes, but it is preferentially used in a therapeutic manner. Coming to the most important topic in a pain management in chronic pancreatitis, chronic abdominal pain is a hallmark of chronic pancreatitis and is a significant contributor to reduced quality of life in children with chronic pancreatitis. Identifiable organic insults often arises for pancreatic ductal hypertension, pancreatic parenchymal inflammation, ischemia, and fibrosis, and in addition to extra pancreatic involvement, including common bile duct pathology. For this purpose, neuromodulating agents are used. So this is an Aspergen Pancreas Committee analgesic ladder. Level 1 is acute intermittent abdominal pain, where there's no non-opioids. Only NSAIDs are used, continued uncontrolled pain. Then scheduled NSAIDs and acetaminophen every 6 hourly, alternating every 3 hourly. If there's a level 2, moderate persistent abdominal pain, we use weaker opioids, continue scheduled level 1 medication. If child is more than 12 years of old, start tramadol as need for breakthrough pain. If it's less than 12 years of old, stop acetaminophen and start hydrocodone or acetaminophen as needed for breakthrough pain. Coming to level 3, severe persistent abdominal pain, we use stronger opioids, continue scheduled level 1 medication, stop weaker opioids, restart scheduled at acetaminophen if stopped, and start oxycodone, oral immediate release morphine, or oral hydromorphone. If there's an uncontrolled severe persistent abdominal pain, we continued uncontrolled pain or unable to tolerate oral, we recommend inpatient admission for pain control. So in addition to this pediatric gastroenterology, for managing the pain, we use a pain clinician, requirement involvement of pain clinician, therapeutic endoscopist, and physical therapist is required. Additionally, a pain psychologist with expertise in cognitive behavioral therapy is necessary to complement to medical therapy. Despite attempts to study alternate non-analgesic intervention to improve chronic pain involving low-fat diet, PERT therapy, antioxidants, steroids, and somatostatin, none have demonstrated convincing efficacy. So endotherapy for chronic pancreatitis, given the hallmark pain symptoms due to ductal hypertension, ERCP is a treatment option. Diagnostic purpose, pancreatic ductal hypertension, stone, ductal stenosis, leak, papillary necrosis. For therapeutic, pancreatic duct, stone clearance, balloon dilatation, stent placement, biliary stone extraction. Nutrition, malnutrition in chronic pancreatitis manifests in up to 25% of children and is often multifactorial. Pain and anorexia, micronutrient deficiency, fat malabsorption, and increased energy expenditure leads to malnutrition in chronic pancreatitis. Diagnosis of pancreatic exocrine insufficiency. 1/3 of children with chronic pancreatitis has EPI. Manifested generally consists of malnutrition, fat-soluble vitamin deficiency, steatorrhea, malodorous or stool, bloating, and abdominal pain. Mostly the pancreatic exocrine insufficient can also be subclinical. Diagnosis is performed in multiple ways. The most commonly is fecal elastase 1 measurement. Endoscopic pancreatic function testing can be performed via direct measurement of pancreatic enzymes and bicarbonate collected endoscopically after cholecystokinin or secretin stimulation. This is a treatment of while using for pancreatic enzyme insufficiency by PERT therapy. We give lipase unit per kg body weight per meal, lipase unit per gram per fat in meal, and enteral formula. Fat soluble vitamin deficiency in chronic pancreatitis. In addition to calorie insufficient, deficiency are common in patients with chronic pancreatitis. Screening should occur every 12 to 18 months or as clinically indicated. Vitamin D screening should be performed in children annually with similar interval screening for deficiency for serum vitamin A and E. Proxy for vitamin K can be obtained with measurement of prothrombin time annually. In children with malnutrition or persistent low vitamin D levels, bone and mineral density should be measured. Additional gastrointestinal sequelae for chronic pancreatitis. Children with chronic pancreatitis have increased risk of gastroparesis and small intestinal bacterial overgrowth, for which symptoms of abdominal pain, early satiety, bloating, and nausea often overlap with the symptoms. Fasting glucose hydrogen bread testing can be used in stabilizing this diagnosis, and antibiotic treatment, including rifaximin, neomycin, metronidazole, can be administered. Endocrine insufficiency and pancreatogenic diabetes mellitus. After chronic damage to pancreatic parenchyma, it is estimated that 4% of children with chronic pancreatitis will develop endocrine insufficiency and diabetes mellitus. Children with chronic pancreatitis should be screened annually for diabetes with fasting glucose and HbA1c. Coming to the surgical management of pancreatitis in children, for those children with chronic pancreatitis who do not respond to medical therapy or endoscopic therapy, there's an availability of total pancreatectomy with islet autotransplantation. The primary aim for this procedure is to alleviate pain from chronic pancreatitis while preventing significant insulin dependence and endocrine insufficiency by islet autotransplantation. The only indication is for this TPIH is refractive pain. So now, after ending with this topic with the clinical care points, a child with first presentation with acute pancreatitis should include evaluation of serum transaminase, bilirubin, calcium, triglyceride, and imaging with transabdominal ultrasound while reserving expanded diagnostic workup for recurrent disease or concerning history. Coming to the medical management of acute pancreatitis, it has 4 domains: aggressive fluid resuscitation and ongoing monitoring, early and oral enteral nutrition, and pain control. Coming to the complication to acute pancreatitis is a fluid collection. That majority of acute collection will resolve without intervention, but increasing ERCP and EUS, endoscopic ultrasound guided gastrostomy can be used for persistent and complicated fluid collection in case of pseudocyst and walled-off necrosis. Genetic testing should be undertaken in children who present with recurrent pancreatitis. Cross-sectional imaging with MRCP. If available, secreting enhancement should be obtained in recurrent cases. Key consideration in pediatric chronic pancreatitis that required a multidisciplinary approach, including pain management, malnutrition, and endotherapy. Coming to the end slide, there's a scope for the further study. Further research to better address quality of life and pharmaceutical and endoscopic intervention in children with pancreatitis is needed. Evolving knowledge and broader detection of risk factor coupled with advances in therapeutic intervention in children has advanced the care of pediatric pancreatitis needs to be implemented in a broader way. Thank you.
Thank you so much, Dr. Purva. It was an excellent presentation and you have covered all the points: causes, treatment, nutritional management, complications, types of pancreatic fluid collections, and everything for acute and even chronic. So let us ask our expert for his comments.
Thank
So
you.
over to Dr. Vishnu. Vishnu sir.
Yeah. So Purva, excellent presentation. I really like the way you summarize the main points, major points. Just a few things which I want to specify, which are the new things which might not be there in this particular review as a practical point. First is the fluid.
Yes.
So there was a saying about the aggressive fluid therapy, but now in last couple of years, it has been now changed and shift towards the aggressive fluid therapy. So it is like just maintaining the normal blood pressures and a normal hemodynamic. So aggressive fluid therapy has gone down now. So if the patient is in the shock or hemodynamically unstable, then only the aggressive fluid therapy as like shock. Otherwise, it should be a normal fluid maintenance or maybe sometimes 2/3 of the maintenance. So that has been taken out from the newer thing. Other than that, you covered very well. Nutrition is very important, as you rightly mentioned. It
Yes.
should be started in 48 hours
Yes.
as early as possible, and start with the liquid and high carbohydrate and low fat and low protein, so that you do the better. The second thing you talked about the pain. Yes, the first pain killer is paracetamol, followed by NSAIDs, and if it is not, then go to the tramadol, and lastly the morphine and the other painkillers. The organ dysfunction you really did well. The for the pediatrician, it is very important that our treatment should not contain antibiotic. The giving antibiotic in pancreatitis or any disease which is not warranted actually makes it complicated. Be it acute diarrhea of viral etiology or even the bacterial etiology. Many acute diarrhea because of the bacteria, we don't give antibiotic. And in the same principle, do not give antibiotic in patients with acute pancreatitis. Even though the child is febrile, even though the child is showing the symptoms of SARS, the fever will stay for 3 days, 5 days, 7 days. But don't give antibiotic, because in the first week of pancreatitis, you will not get infection. The infection sets in when there is a fluid collection and in the second or third week, if it is going to get infected. And the point is about the PPI. So till last year, we as a pediatric gastroenterologist or adult gastroenterologist used PPI left and right, thinking that the PPI are used in pancreatitis for the two reasons. One is it decreases the volume of the stomach by decreasing the secretion of the HCl by 40%. So 40% hydrochloric acid secretion will go down. And the second thing is, we thought that having a pancreatitis leads to a lot of gastric stimulation, because there is when the fluid collects, it gives rise to the edema of the stomach and edema of the transverse colon. So at both the places, it leads to an inflammation, and that is why we need PPI. But now, this year, 2023, the PPI also has taken out from the treatment plan. So the treatment plan is just a fluid, diet, and pain control, and watching for the organ dysfunction. You mentioned about the pseudocyst, and you rightly mentioned about that not all the pseudocyst you need to intervene. It doesn't depend on the size. Initially, it was like more than 4 centimeter, yeah, more than 6 centimeter of pseudocyst. You need to send them for the surgery and pseudocyst drainage by the surgery or endoscopy. Nowadays, pseudocyst resolves over a period of maybe couple of patients. We waited for 9 months and pseudocyst resolved. And presence of pseudocyst again is not an indication for starting the antibiotic. So pseudocyst, unless got infected or sometimes it leads to the obstruction of the GI tract, then only you need to intervene. The rest of the topics were very well covered, and I think for a practitioner, you will not come across many of the patients of recurrent pancreatitis or chronic pancreatitis. But whenever you come across the MRCP you mentioned, but I would keep this investigation to the minimum, bare minimum. Unless and until you are planning for some endotherapy, I don't recommend to go for the MRCP, because now with the ultrasonography, you can easily detect the stones or the fluids, strictures, everything you can see in the pancreatic duct. Otherwise, pain control in the chronic pancreatitis was very well covered, and fat soluble vitamin deficiencies, yes, needs to be established. Fecal elastase 1, we don't do because we know that the 10 years or 20 years, it will take time for the exocrine or endocrine particularly the exocrine insufficiency or deficiencies to occur. So we rely on the stool for FODT, which is cheaper and easily doable test. Fasting glucose, yes. Many of you mentioned fasting glucose in the chronic
Hydrogen.
pancreatitis. Yeah, but one of the important points as a pediatrician we should be remembering, in acute pancreatitis patients also, after 3 months or after 6 months, we should document the fasting glucose, because 1 or 2 patients I came across, they presented with acute pancreatitis, and in next 6 months or 8 months, they developed decay. So that 1% of the patient or less than 1%, whatever it is, we should not miss. So the fasting glucose in the follow-up patients of acute pancreatitis, and the surgery is rarely needed. I remember in so many 15 years, only 2 patients were refractory. We could not able to control the pain, and they were referred for the surgery. Celiac plexus neurolysis, you just briefly mentioned, but I will just mention. It is the ultrasound guided puncture of the celiac plexus, and there we put alcohol so that it gets neutralized, and the pain signals from the pancreas will not reach to the brain. So that is what we call as a celiac plexus neurolysis. It works for 6 to 9 months, and after that again you have to repeat when the pain starts. So wonderfully covered. I just thought there are a few points I should be mentioning again and again. And the biliary cause, we see a lot of biliary cause. The patient presenting with pancreatitis, and you find that there is a biliary system dilatation, and they're referred for the surgery for choledochal cyst, but they are not choledochal cyst. It is the obstructed biliary system, and you do the endoscopy and everything gets resolved. Yeah, these are the few points I thought I should share.
Thank you so much, sir. Thank you, Dr. Purva, and thank you, Dr. Vishnu, sir. And sir has really guided us very well, and he has given the practical points. So we all pediatricians would be really beneficial for this topic. Now I request Dr. Mohanty, sir, to comment on both the articles.
So, sorry, first article I have shared, rather we should, in our setting, we should rather think of conducting such studies with certain advanced gadgets which are now available with us. So that's given, that is over. The second topic, I think Purva has done very well, and with an expert like Vishnu, he has clarified everything. The day is done to me. It's very good. Again, I have to re-emphasize that earlier, these kids usually land up with the surgeons, pediatric surgeons. They catch it like a pain abdomen, catch it for there, and certain interventions are done, whether justified or not justified. But with this knowledge, our pediatrician, I think this is an area where general pediatrician also can play a role. The high index of suspicion, epigastric penetrative fullness in the epigastrium, and you should raise the suspicion very high and investigate it accordingly. Do amylase and lipase and do ultrasound, you will immediately get the diagnosis. And as you saw, the management is not critical, not very difficult. It can be managed in our own setting. But once you, another thing is recurrent pancreatitis. You may not get the first episode of pancreatitis to come to you. You may get the second episode, third episode of pancreatitis before they report to you. So these things also should clearly be excluded. But this is not a first episode, it's recurrent or first episode. In Kerala, you see a lot of tapioca is consumed. The chronic calcific pancreatitis in adolescents and adults are common. This should also be borne in mind. We may get some reference from that side. Once you decide a referral, better to send it in right time, where the facilities exist for the detailed investigation and intervention, rather than delaying unnecessarily. If you go by this dictum, the PCNA has laid down, and this, if you are not used antibiotic, as Vishnu has very rightly pinpointed, the fever is because of necrosis, not infection. And infection, if at all sets in, comes in second or third week only. So not in a hurry, we should start antibiotic. It is doing any good to the child. So see these few carry home messages from Purva and Dr. Vishnu. Very clearly he has summarized and given the message we followed, and it's a very relevant topic. Although I was hesitant to give this topic initially, but I thought such suspicion should come to the general pediatrician mind so that things are diagnosed in right time before it worsens further. Thank you.
Thank you so much, sir, for your valuable comments. And now I request past Maha-IP President, Dr. Ramakant Patil, sir, to comment on the articles.
Dr. Amol Pawar is there. Sir, आहेत का?
हाँ है ना अमोल है.
Yeah.
Dr. Amol, please.
Amol sir? Yes.
Ramakant Patil sir nahi आहेत madam.
Sir. Any other person, senior person wants to comment on the topic? Vishnu sir, may I request you to tell the signs and symptoms, how to suspect about this particularly acute pancreatitis?
So, if the patient says there is a pain in epigastrium and the child prefers to bend the knees and keep it at the chest, that is very classical of the pancreatitis pain. Sometimes in the older child, they can also explain that the epigastric pain going back to the radiating to the back. The problem comes when the less than 5 years or 6-year-old child coming with the pain. But any pain which is making the child uncomfortable enough not to walk properly, like what happens in the appendicitis pain, the child limps. The same way the child bows down and
until they get it.
Yeah. And even in the smaller kids, what they do is they go lie on either on the abdomen or on one side they will come and do this posture, and the pain which is this classical pain we should not be missing. And for the diagnostic purpose, I think both amylase and lipase should be more than 3 times, not the amylase, because with the cases we see like mumps and sometimes we see enteritis, that also sometimes give rise to a increase in the amylase. So I think amylase and lipase, because lipase is very specific to the pancreas, both should be done, and it should be more than 3 times. Only thing is, in chronic pancreatitis or in the recurrent pancreatitis, sometimes you will not get that. But the sonology, the ultrasonography, which will pick up the changes of chronic pancreatitis. So all the clinical history, the amylase and lipase, and the ultrasonography, these all 3 things are must to diagnose and confirm the pancreatitis.
Thank you. Minas sir?
Vishnu sir, I must compliment both the Purva and the Vishnu has done exemplary job. I need to ask, what are the imagings beyond sonography? Suppose at many time you may not be getting good sonologists picking up the inflamed pancreas or for whatever reason. What is next beyond sonography?
Yeah. So I would reserve the CT scan in the pancreatitis, because by doing the CT scan, we are not justifying the radiation. The CT scan is only reserved to a patient who had a severe organ dysfunction. So if your child of acute pancreatitis had an organ dysfunction, which is persisting more than 48 hours, then after treating for 48 hours to 72 hours, then only you do the CT scan, but only to the severe cases. The milder cases, we should not be doing the CT scan. Why so? Because I am very scared of doing the CT scan left and right by our own colleagues. There is a beautiful paper last year. I think that should be discussed. Sometimes if I have paper, I will share with the team. The one CT scan increases your hematological malignancy by 10 times to 20 times. One CT abdomen. There was a beautiful paper which elaborated that the children which have done the CT scan at less than 5 years of age, at 20 years and at 30 years, how many got hematological malignancy? And that data is alarming. So I would keep the CT scan only in the patients of severe cases with organ dysfunction, which is persisting for more than 48 hours. Then I will come to know what is the necrosis and CT severity index. Other than that, even though I know that the CT is showing necrosis, some acute inflammation, some swelling, something, my management is not going to change. My prognosis is not going to change. So I would not do the CT. MRI, yes, MRI abdomen can be a safe, but the MRCP, I would again save, because one MRCP is 10,000 to 15,000 rupees. And if I do the MRCP and I know that there is some stone and the PD is dilated 4 mm, but I'm not going to do the endoscopic management, then I would not do the MRCP. Only rely on the sonologist. That's all.
And Vishnu, last question from my end. What are the sono findings of pancreatitis?
Sonological findings. There are 4 findings which are must. One is the pancreatic swelling, which is swollen pancreas, which is usually there. Only in few cases, only you will not have the swelling of the pancreas. Second is peripancreatic fat stranding. Third is peripancreatic fluid. Some fluid will be there. It is either a mild, moderate, or severe, massive. The fourth is the gastric wall thickening or pseudo thickening like picture. Fourth is again if sonologist is good, then he will mention about the small bowel edema or a large bowel edema, and he should mention about the gallbladder, common bile duct, IHBR, intrahepatic biliary radical dilatation, and any stone in the CBD or in the pancreas, because that will change the management. So if the dilated CBD is there, then I am thinking about the biliary pancreatitis, where I should be doing the MRCP at earliest, because I need to intervene by the ERCP within 48 hours so that we will not going to continue the damage. So this little thing in the ultrasonography, they should be mentioned about the common bile duct, IHBR dilatation. And that is why there is a role of doing the liver function test along with the GGT. So you know that, are you looking at a biliary pancreatitis?
Thank you, Vishnu. Thanks a lot.
Thank you.
Yeah, Dr. Swati, Thanksgiving. You only do now.
Okay. I guess we are finished with the questions. On behalf of Raigad IIP, I express my sincere gratitude towards our experts, Dr. Atul sir, Dr. Vishnu sir, speakers, Dr. Rajeshri and Dr. Purva Jain, guest of honor, and our chief guest, Dr. Basavaraj sir and Dr. Vasant Khalatkar sir. The presentations were really informative, engaging, and thought-provoking. And I'm thankful to our very own AHA President, Dr. Chitra Kulkarni Madam, and Dr. Mohanty Sir for continuously guiding the speakers and contributing to make this journal journey an excellent one as always. My deepest gratitude to all the doctors who attended today's journal journey for their time and attention and patient listening. That's it.
Thank you. Dr. Vikas More, sir, you want to contribute for something related to the topic?
Next episode.
It was absolutely very important topic, and it has definitely given us some newer insights to have a different approach to these new important topics. Especially, I remember in my initial days, pancreatitis in children was very scary for me, but after listening, we can have some, as a general pediatrician, we can definitely at least have insight like how the disease is progressing and at what time we need to refer the child and how to treat the child. Like referring the child is not only a solution. We need to be active part of the treatment, even though the baby is referred. We should be in touch with the intensivist and we should follow, because the baby is again going to come back to you. And the long-term follow-up is also needed in such cases. Secondly, this alcohol substance abuse and the longer things are very interesting and very, I will say, I was quite curious about this paper, and very nicely designed paper, and it has again underscored the importance of reading the this papers regularly and being in touch with academics, and it will definitely change our counseling in our routine OPD practice. Thank you so much.
Thank you, sir.
Thank you, sir. Next journal journey announcement.
We will
Gangolia,
again
sir. Yeah. Amol Pawar, sir. Gangolia, sir. Next journal journey announcement.
पल्लवी मॅम मीटिंग recording stop करा.